So our next presenter is Mrs. Yolaan Andrews. Yolaan is a Human Rights and Key Population Program Manager at the Networking HIV and AIDS Community of Southern Africa, otherwise known as NACOSA.
Sorry, I just had to put it a bit lower. Hi, everyone. NACOSA is a Global Fund principal recipient. We were supporting the People Who Use Drugs program from 2019 to September 2025. So we've had an amazing experience, and I just want to give an appreciation to people who use drugs for their lived experiences, sharing it with us, because it just makes programming better. And then also just very quickly with my seconds, just to give a great thanks to all the implementers in our 8 districts for the work that they've done and their contribution to this finding. I forgot. I must actually move it. I thought Andrew would just move it for me. You know? So
you have to do work.
I have to do some work. Oh, damn. So just in terms of why we did what we did is because the WHO has indicated that approximately 125,000 deaths in 2019 were attributed to opiate overdose. But if you look at South African data, we're not really seeing anything there. We want to say that the Sekendo data provides some perspective, but it's not large enough for us to look at programmatically what we need to be doing as well as policy. And then also in terms of implementation, we do know that we are lacking in terms of our engagement through peer programs on asking people who use drugs about their overdose experiences. So NACOSA made the decision to actually do a survey, a very short survey, 25 questions. We used Microsoft Forms, so you could do it on your cell phone, and we had peer educators in 8 districts go out and engage people who use drugs over a certain period of time in July. From the 4th of July to the 12th of July was a very short time frame. And we actually reached 1,037 respondents of people who use drugs in the 8 districts. Obviously, most of them are males. I'm not going to go through the demographics, but what I want to highlight is that 64% of those respondents were homeless. Multiple drug use was indicated. 66% indicated they used multiple drugs, with 793 saying opiate, but also a high number of crystal meth, mandrax, and crack cocaine being indicated. We were surprised a little bit to hear that at least 72% indicated that they had never overdosed before. But those that had indicated that they experienced an overdose, 96% reported that it was an opiate drug overdose, and 33% reported it was related to stimulants. For those that did indicate that they witnessed or knew, there was 55% that indicated that they witnessed or knew someone that overdosed. The scary aspect, though, is that 72% indicated that it had been a fatal overdose because no help was being provided. Now, as I mentioned before, many of the respondents were actually homeless, and so when they said they actually had experienced an overdose, 73% indicated that it happened outside in the street or park, and those that indicated overdose happened, 56% indicated that it happened during the day, but a large percentage, 25%, indicated early morning, and 19% indicated at night when help is not necessarily available or the services, emergency services, are not easily accessible. 45% indicated that they reported or witnessed seen an overdose, that help was not available, and those that indicated that help was available, they usually indicated it was emergency services or community. What was worrying for me as an implementer is that a large amount of them, approximately 55%, said they did not know how to prevent overdosing. So this clearly shows that we have failed as a program in terms of educating people about how to prevent or manage overdose, and that's something that one should continuously work on and not make assumptions. And then 81% said that they were not even familiar with naloxone. So in terms of when we looked at that, obviously we said we need to actually be doing something about it, but it's really hard in a country where there's very few options registered in the country, as well as there's certain regulations in terms of administration of naloxone that makes implementation difficult on a wide scale. So we made the decision to implement a pilot in Umgunglovo in KZN and in Nelson Mandela Bay in Eastern Cape. And what we did was we actually provided a small little kit that had naloxone, which was scripted for that patient by a doctor, as well as a sterile needle, and also we had had mouth resuscitators in case CPR had to be formed for those that were experiencing a stimulant overdose. And what we did was we looked at about 25 OST patients in each district, as well as 25 needle and syringe patients or clients as well, so that we could wide-scale the availability and the testing of this pilot. So overall, 119 of our people who use drugs went through this pilot, and we also trained their treatment buddy, if you want, methadone, because methadone overdoses is possible, but also for those that were homeless, that were operating as a needle and syringe program, we also knew that they needed someone to be able to administer naloxone to them if needed. So we trained a fellow buddy that was staying on the streets with them so they could buddy each other up and partner each other up to support each other. So what we did was we provided CPR training to all the staff at the implementers, and they then cascaded that training to the clients as well as to their buddies. We also provided the kits to them and documented the use of those kits. So what was the outcome of this overdose pilot? The outcome was very simple. It works, it's easy, do it. That's it, plain and simple, right? So of the 119 that we gave, we had a 99% success rate. There was one case reported of overdose, one fatality, but that was related to benzo, which we had not factored in as part of the overdose prevention and management. And another fatality that could have been avoided if we had different options or diversification of naloxone or Narcan was related to a client being away from the home, away from their treatment buddy who could then administer. So when they were outside, there was no one to administer the naloxone to them. So in short, I mean, there was very positive factors, strong community engagement, there was effective training initiatives, the buddy system clearly worked. The unintended consequences, though, was trying to explain to people why we were providing naloxone when they thought we were encouraging drug use and not understanding the principles of harm reduction. And then also the fear and stigma from family members that have been asked to be part of the buddy system. Some of the other challenges were also in terms of engagements with the communities, but luckily for us, the implementers have strong advocacy officers in those communities so that we're able to then meet those requirements in terms of sensitizing, educating, and motivating support. So my last slide is purely a call for action. I do understand that naloxone is registered in our country and it's really affordable. I believe, if I'm not mistaken, it's less than 40 Rand for an ambule. So it is a cost-effective means of preventing overdose. But the reality is that there are people that are not necessarily comfortable in administrating an injectable, which naloxone is registered in our country. So what I'm asking for is that we really diversify the options available in the country. Let's bring in more products so people have choices about what they want to use actually to manage an opiate overdose. And we know for a fact that we have police officers that are open to supporting overdose management, but not necessarily have the training or are comfortable around naloxone. The other thing that I'm asking for is that we really consider decentralization at a community level. These implementers know what's up. They have the skills and the capabilities, as well as the relationships with the district health to be able to provide and expand overdose management in the field. I'm also asking for naloxone to be rescheduled as a Schedule 1 over-the-counter medication that you can get without a doctor's script, so that it makes it easier access and lack of a stigma or judgment for anybody to be able to access that naloxone. I'm also asking for expansion of training to community healthcare workers, to ward counselors, to any person on the street to understand how easy it is to actually save a life. And then I suppose the last point that I just want to say is that we need to just be educating people to desensitize, the stigma that there is around the availability of different options to manage overdose. Thank you so much.